and fluid can build up, increasing the pressure. So some other causes could be cerebral edema, hemorrhage, infection, or blockage of CSF drainage, so like by a tumor. And a lot of these things kind of go hand in hand. So like DIC, we were talking about the risk of stroke. Hemorrhage can then increase intracranial pressure. So a lot of these things you kind of want to be thinking about. Brain mets are 3 times more common than primary tumors. So usually if it's a tumor or a mass that's causing the increased pressure, it's going to be from metastases. Some early symptoms could be headache, relief after vomiting, nausea, projectile vomiting, visual changes, memory or personality changes, or lethargy. So these are really the things that at the bedside we're seeing firsthand. So that's why you always want to be, keeping these emergencies in mind and thinking, why are they suddenly so lethargic? There's a lot of things to rule out, but, this is where we're catching it firsthand and we're really the advocates. Late symptoms, they're going to be bradycardic, have abnormal breathing, widened pulse pressure, coma, and seizure. The most common cancers that cause brain mets include lung, breast, and melanoma. So those are good things to keep in mind. So interventions, again, maintaining the airway. The patient is going to be on bed rest with head to bed at 30 degrees. Passive movements only. So if the patient is having increased intracranial pressure, you want to try to avoid them coughing, vomiting. You want to avoid constipation, because these are all things that can increase the pressure further. And energy conservation, because it's going to affect their mental status. And this isn't something that we can treat very quickly, so you want to be conserving their energy. Superior vena cava syndrome. This is a narrowing or blocking of the superior vena cava from a tumor or a thrombus, resulting in decreased cardiac output and blood return to the heart. The most often the cause of this is non-small cell lung cancer that causes tumors that makes this blockage. Symptoms would be dyspnea, cough, orthopnea, so not being able to lay down when they're sleeping and breathe comfortably. They'll have upper extremity swelling, head fullness, vision changes, chest pain, venous distension, and difference in blood pressure between left and right. So that's where our nursing assessment skills really come into play, because these are things that we can identify, checking between the two sides if we are suspecting something like this. So chest CT is most common. Usually this kind of patient can't lay flat to do an MRI. And nursing interventions always protecting the airway, because with all that swelling in the upper extremities, that's a concern. Energy conservation and avoiding right-sided positioning, because that's going to impair venous return. Spinal cord compression. So this is when a tumor invades the epidural space, or when bone mets cause pathological fractures that invade the epidural space. With this, early detection really is key, because if this is occurring and we are compressing the spinal cord, this is something that if it's not addressed is going to become a permanent disability for this patient. So we want to monitor bladder and bowel function. So autonomic dysreflexia, I think we're all a little familiar with that. When patients lose that ability to empty their bladder and bowel, this might be something that happens. And taking back pain very seriously, which, we have a lot of patients with chronic back pain. They're not getting out of bed really well. It's a common thing we see, but this could also be a pathological fracture in the spine. So very important if they have bone mets to be considering that. An X-ray can show a false negative. At least 50% of the bone is destroyed before you can see it on a plain X-ray. That's why we usually do an MRI for this. So symptoms, again, is that back pain. which is very challenging because a lot of people have back pain. It can be caused by a lot of different things. But in spinal cord compression, the pain is usually worse when they're flat and exacerbated by coughing or sneezing. Nursing interventions, if somebody was to lose, function with a spinal cord compression, is going to be a lot of, case management and planning how they're going to function at home, because something like this is really going to change their life and their lifestyle. Cardiac tamponade. This is when fluid in the pericardial space compresses the chambers of the heart and blood flow is inhibited. So it begins as a pericardial effusion, and then it becomes a tamponade when the patient is hemodynamically unstable. Some risk factors here are any kind of malignancy, chemotherapy that increases capillary permeability, and again, that's something you'll find out as you're researching the chemos you're going to be administering, radiation to the chest, and infection. Symptoms are going to be fatigue, dyspnea, chest pain, palpitations, and muffled heart sounds early on. And then as it progresses, they'll have dyspnea at rest as well, increased chest pain, orthopnea, cold sweats, anxiety. You might have absent heart sounds if you have a lot of fluid, edema, and jugular vein distension. So again, we'll probably do imaging to diagnose this. It's very sensitive on CAT scan, and we'll be giving oxygen, recognizing for any progressive changes, and energy conservation. So you guys all have a little cheat sheet that kind of does a quick summary of all the different emergencies, so it's a good reference. Any questions so far about anything we talked about? Anything new that you didn't know before?
Have you guys seen this before, you grads? Have you seen any patients with any of these oncologic emergencies so far? When you were on 6 or 7, because we have both oncology patients on 6 and 7. Sepsis. And what were the patient's symptoms?
She was tachycardia, she had fever, blood pressure was low.
Okay.
Alright, so I have a case study that I wanted to talk about. It kind of pulls in a couple different emergencies that we went over. This is actually a patient that we had on the unit. So the first part of it is a real patient scenario, and then we kind of added some things in on our own to bring in some other emergencies. But in this case, we had a 76-year-old female with a history of CHF and smoking. She was newly diagnosed with small cell lung cancer and was admitted with shortness of breath and back pain. Sounds kind of familiar, no? So she's on 2 liters of oxygen, and a chest x-ray and a bone biopsy confirmed that she has a 5-centimeter bone lesion to her right scapula. And the bone lesion is causing venous obstruction. So the decision is made to begin chemo inpatient due to the possible cardiovascular compromise. So we don't often begin chemo so quickly inpatient when it's a new diagnosis. Usually we stabilize them and they follow up outpatient. But in this case, she was at such a high risk for cardiovascular compromise that the decision was made to start right away. So her potassium comes back at 5.4, and the patient takes aldactone and torsemide for her CHF, which we know. And she's been taking ibuprofen around the clock for her back pain, which is an NSAID. So based on our cheat sheet, what kind of emergencies do you think she's at risk for?
Superior vena cava.
Yes. So the superior vena cava syndrome is huge because she has that tumor that's causing a venous obstruction. Anything else?
Tumoralysis. She didn't start chemo yet, right?
Definitely too
But
early,
you
he
don't need
says.
to,
Yes.
like you mentioned.
So she hasn't started the chemo yet, but she has a cancer that's rapidly growing, and she has hyperkalemia at baseline. So now that she's going to be getting chemo, that puts her at even higher risk. And I think we had a couple more. Anything else you guys see? Yes, she could be. Definitely. Another thing has to do with her back pain and the ibuprofen she's been taking. So that's an NSAID that she's been taking around the clock. And with her small cell lung cancer, those both put her at higher risk for developing SAADH as well. So it's not usually something we think about, but taking NSAIDs really does put you at higher risk. And then also anaphylaxis, because it's her first chemo that she's going to be getting. So this patient returns 20 days post-chemotherapy. She received etoposide and cisplatin for her small cell lung cancer. She's lethargic, has a fever of 102. She's nauseous and vomiting for the past week. Complains of burning on urination and back pain for the past 2 days. And then we included some additional information there. Her white count is only 2,000. Her absolute neutrophil count is 500. Her blood pressure is 88/50. Heart rate is 120, and her lactic acid is 3.0. So what oncologic emergencies is she at risk for now? Sepsis. That's right.
Neutropenia,
Yes, and she's got neutropenic fever. So we know that her mortality rate is increasing the longer we don't treat her. So with her situation specifically, an important thing I wanted to point out is always looking up the medications that these patients are getting. Especially on the 6th floor, we don't really give chemo every day, so we always want to be looking up what side effects could they be having, what information do we need to know about the medications. So the cisplatin actually has a nadir of 18 to 23 days, and the etoposide is 7 to 14 days. And the nadir, just to refresh, is the point at which your blood counts will be the lowest. So these are myelosuppressive medications. So this patient's really at risk for, if you combine the two, a total of 7 to 23 days after her chemo. So it's a pretty long time to be, preventing infections and monitoring for that. So it's no surprise that she ended up here with sepsis. So her nadir, right now, her ANC is at 500. And here, I think we talked about that, we do 1,000. Puts them at neutropenic precautions. And then another thing in this case that puts her at risk is she was nauseous and vomiting at home. So the cisplatin actually has a very high risk for nausea and vomiting. The different meds are given a certain risk factor for that, but that's a very high one. So she likely was home and became dehydrated and developed a UTI. So this part of the case really points out how teaching is so important on discharge. So these are, all things that we know, but we need to be able to communicate that to our patients, things they should be watching for at home, things they should be doing to prevent any of these emergencies. So for this patient with a low white count and risk of infection, what kind of things would we want to teach her when she's leaving the hospital?
Hand hygiene, not to eat raw fruits and vegetables.
Definitely.
Cold and flu season.
Coming to the hospital right away with a fever too is really important, because for 7 to 23 days she's at risk for neutropenic, being neutropenic. So she's not going to know that her white count is 2,000. So if she has a fever, she really needs to come right away. So throughout our whole time at this conference, really such a strong theme was that nursing is so important in managing oncologic emergencies. I mean, we're seeing it firsthand and identifying it. We're seeing who's at risk. We're educating our patients. So I really just wanted to, be able to bring this back to you guys and, just emphasize how important our role is. So I hope that this was beneficial and you can bring this back when caring for your patients. Any other questions? Any comments?
I know this is especially important to the new grads, right? Because we actually just added this to the curriculum for the new grads, and they did a CE Direct course on this and also an iLearn module. So that was perfect, Emily. You really hit a lot of really important points because we're trying to keep these patients safe. So great job. Let's give her a round of applause. So if you guys would please just fill out an eval.
Oh, you have a question.
Here's a question.
I know. So, I love case studies because, they prompt us to think. So, just a thought I had, I know you went to this conference, is there anything we can do, proactively, you have a patient getting chemo,